Good afternoon, maybe good evening to some. So thank you so much for joining the keynote section today. Welcome our speaker, our Professor Haniki. Thank you, our keynote speaker, and also welcome our participants. So I would like to extend a warm welcome to all of you joining us today for the Global Water Exchange Summit 2024, co-organized by Research Management Office and Virtual Exchange Center from School of Continuing Education, Hong Kong Baptist University. The summit aims to provide a dynamic forum for the exchange of insights, exemplar projects, and innovative research in the realm of virtual exchange. It aims to foster collaboration and share knowledge among educators, practitioners, and administrators around the world who are committed to enriching teaching and learning through virtual exchange. Our summit this year places particular emphasis on the theme of cultural exchange and global citizenship. So before we start the keynote section, I want to remind everyone that we encourage your participation. Please feel free to submit your questions in the chat box throughout the section. We will have a Q&A segment following the keynote. Please take note that the section will be recorded and be uploaded to YouTube. So kindly mute your microphone during the section. My name is Anna, and I represent Global Virtual Exchange Summit Organizing Committee to orally invite Professor Haniki to share the insights today. So Professor Haniki earned his Doctor of Pharmacy and completed a postdoc fellowship at University of Tennessee in U.S. and he is now an international Islamic University in Malaysia, where he holds positions as head of department and deputy dean, public affairs, before being appointed acting dean of the Center for Foundation Studies in 2018 and head of internationalization and global network for the Columbia of Pharmacy and also Medicine in 2019. So Professor Haniki is very active in teaching, training, and also supervising both undergraduate and postgraduate students on various research initiatives. And particularly, he's focused on tobacco control. So he serves as an advisor for a cleaning house for tobacco control at the National Poison Center in Penang, and is also a core team member of the Disease Control Division at the Ministry of Health Malaysia. So he's very renowned in Malaysia in helping with the tobacco control that. So he also been appointed by the Ministry of Health Malaysia to various committees to help to take control of different things related to tobacco control, like e-cigarettes as well, and health technology assessment for smoking cessation then. So I believe that he will be, but we are very honored to actually have him to share us the topic, virtual program on tobacco use disorder between IIUM and also the University of Pittsburgh, USA. So now may we have our, applauses and welcome our keynote speaker, Professor Haniki, to share us his presentation. Professor Haniki, please.
Thank you so much, Anna, for the kind introduction, and also to the invitation as a keynote speaker at the summit. Good morning and good afternoon and good evening to all watching. So I'm going to share with you today basically an experience where we developed, implemented, and assessed a virtual training program specifically on smoking cessation in particular and tobacco control in general, prepared by the members at Faculty or Kuliah of Pharmacy and also Medicine here at the International Islamic University Malaysia, specifically for pharmacy students from the University of Pittsburgh, U.S.A. I have no conflict of interest for this presentation. So let's all go to the next slide. Okay, giving all of you some sort of historical background to how we ended up having this program. Initially, I was invited to share my experience in tobacco control by my colleague, actually a friend from the PharmD course in University of Tennessee. So she currently working at University of Pittsburgh. And then during COVID, she thought, well, it's good to have a virtual sharing of experience for her pharmacy students. So that happened in late September 2020. And that was followed by an appointment as a preceptor for the Year 4 University of Pittsburgh School of Pharmacy Experiential Learning Program. So at the University of Pittsburgh, the Year 4 students have the option to do certain experiential learning locally and also internationally. So 3 students actually signed up for a 1-month physical attachment at my university, International Islamic University Malaysia, from 21st of March to 22nd of April 2022. But because of issues related to COVID-19, they couldn't come. And we then we decided to change it to a virtual program, focusing on smoking cessation, and also embed a little bit on tobacco control. So for those dates, we had several virtual meetings through many platforms, and also with the person in charge at University of Pittsburgh, as well as students to cover details of the program. And it's a good initiative from the University of Pittsburgh because once they appointed someone as a preceptor, they immediately provided resources related to preceptorship. They give online links to training modules, experiential learning manual for both preceptors and students, as you can see here, as well as resources and management system, program information, and so on and so forth. So this actually provided a good starting block for me as a preceptor in terms of roles and responsibilities. And I'm sure most of you are well versed with various models, various models for virtual teaching and learning, and also maybe even distance education, and so on and so forth. So we sort of adapt and adopt because we are not experts in education per se, but we have the know-how, we have the knowledge, but we followed ADDIE model as shown here as like a model for us to use in order to ensure that we are systematic in our delivery, from the development to delivery to the assessment of the virtual program. So as you can see here, the first A stands for analysis. So we talk to the students, we talk to the person in charge at the University of Pittsburgh, identifying the basic needs of the group, the educational goals, the proposed learning environment, which is virtual, and also the limited the knowledge and skills of the trainees were detected. And then we moved on to the design of the program, the virtual programs, which included learning objectives, the assignments, the assessment instrument, the lesson plan, and the tools. Then after we designed it, we developed the write-up, we produced, for example, the lecture materials, the contents, the triggers for the problem-based learning, okay? That was mostly prepared by a colleague from the Faculty of Medicine, which I will share later. Then the implementation part. Okay, this was, of course, the most exciting component where the product is put into application. process in practice with the specific learning environments that we design. So there were definitely some modifications that occurred, and we had to be flexible because, as you know, time-wise, we were about 12 hours ahead, so there's this time difference, and sometimes they had issues, sometimes family issues, personal issues, or also academic-related issues that require us to reschedule and whatnot. But anyway, I think all in all, you can see that we managed to cover the intended learning outcomes throughout the about 1 month period. Okay, so the last part is the evaluation. There are many ways to do this, of course. So we decided to do both formative and summative assessment. Basically, they had a pre-programmed online quiz that they answered, and then they had a series of lectures where there were discussions, and there were specific formative assessment done for the problem-based learning component, and then they redo the quiz and as a post-assessment, and we then compared their scores pre versus post program. Okay. So we listed the program learning outcome as to for the students to be able to explain the mechanism of nicotine dependence and assessment, the cognitive and behavioral strategies to support smoking cessation. Of course, because these are pharmacy students, a good portion of the discussion will be on the pharmacological management of nicotine dependence and tobacco use disorder. Bear in mind there are differences in approaches to manage nicotine dependence or tobacco use disorder between Malaysia and the US. Okay. We also included issues related to e-cigarettes because that was an emerging epidemic in both countries and beyond. So we thought that would also be part of the learning outcome so that students will be able to discuss issues related to e-cigarettes. And I think the most important part was to get the students to apply the models for smoking cessation intervention to actual patients. So we were lucky in the sense that when we talked to the people at University of Pittsburgh, especially my colleague, Karen, Dr. Karen, and also other faculty members there, they already identified the opportunities for the students to actually have an actual patient, actual patient, because they run like a clinic, a community health clinic in the area, and they identified a smoker who's willing to then join in, and then also join in a virtual presentation and case discussion, her case, and whereby the students would be intervening, providing the service. And we here then would be given the opportunity to also join with the consent of the patient, of course, to join the session and then use that for more formative assessment, whereby we provided points in terms of the good and the to improve points for smoking cessation in actual patients. So the outline of the program, when we decided to include topics on the activities that so that they would have the knowledge needed to discuss and then later apply. So we assign the topics earlier. Then we discussed with the students. They said, okay, these are feasible. The timeline is okay for the about 4 weeks or so, and they have a buffer of 1 week, whereby if we need to replace or do anything, we still have the flexibility to do it in the 1 week remaining after the 1 month. So we identified the topics, the activities, and the assigned readings, so that we go over with them during lecture sessions and also discussion. And we provided the links and the resources and the reference materials for them as well. Okay. So as I mentioned just now, we also did a pre-assessment quiz. Item 1 to 5 basically are demographics. So there were 20 items that we asked the students to attempt as a multiple choice question, from a little bit on epidemiology, tobacco control strategies. If you see there, the 5 is the 5R on medication, and focus a bit more on the medications part, as I mentioned, because these are pharmacy students, and understanding the selection of the agent or drugs, and also the administration, as well as the expectation in terms of both effectiveness and also potential adverse or side effects. If you see item number 19 is basically asking about assessment of nicotine dependence using Fagerstrom test. Okay, and also a little bit on application of the knowledge regarding medication selections and use, as well as monitoring parameters in various settings, because as you know, pharmacists may end up in the community practice for the retail pharmacy, or they may end up in health clinics or hospitals. So the tools available may be different, and also the kind of patients and service can also vary. So we try to give the students some scenarios whereby if you see a smoker versus a vapor, what would be the tools, and also maybe certain tips of practice regarding, if you see number 24 here, the question is about caffeine. Okay, so it's good for the pharmacist to also assess the amount of caffeine intake, as well as other medications, obviously, when they want to intervene or help patients. So all these nitty-gritty issues, and also update issues, for example, the EVALI, question number 25, whereby certain users of e-cigarettes experience what we call electronic cigarettes and vaping associated lung injury, or EVALI for short. So we wanted the students to also be aware of recent issues or developments related to both cigarettes as the main tobacco products, as well as e-cigarettes. So we went over with the students again as a refresher, why nicotine is highly addictive, what makes tobacco use harmful, because I'm sure at this day and age, people would not straight away say that tobacco use is safe anymore. People are aware. However, you'll be surprised, some people still try to how do I say, claim ignorant, being ignorant about the harmful effect of tobacco. So how would the students then be able to highlight the diseases that had been established in terms of causality between smoking, secondhand smoke exposure, and now third-hand smoke exposure? So all these were discussed in detail so that the students are able to relate the diseases, so that they can motivate the smoker or the vapors to quit immediately or as soon as possible, given the high risk of so many diseases that had been associated with tobacco use, particularly smoking. Okay, and we want them to be able to appreciate, because there are still even health professionals out there saying that, oh, it's just a habit, nicotine is harmless. Well, being a psychoactive chemical, nicotine has a very high affinity to certain acetylcholine receptor in the brain, and that elicit the effects that are experienced by the users. So the students need to appreciate it from several perspectives. One, so that they understand to a certain extent how addictive nicotine is from tobacco products, and also why is it so difficult for some users to quit. Okay. Which then continues the cycle of nicotine use, especially given the fact that they got a surge of dopamine release from the nicotine interaction with the receptors, acetylcholinergic type receptors, especially alpha 4 beta 2. And when they stop using tobacco products, the dopamine levels would reduce, and the reverse effects, which are called withdrawal symptoms, including stress and anxiety, would then set in. And the most common way that a smoker or a user would cope with this would be to reuse the product, to light up a cigarette or take another puff of their e-cigarettes. So we also highlighted to the students that whatever the smokers tell you, their experience with smoking, they are mostly true. They say, oh, when I smoke, I have a less anxiety and tension. Yeah, you can see that the effect of beta endorphin and also GABA. I have better mood due to serotonin. I learn better. I can memorize things better. I can concentrate better. Or they have, of course, dopamine gives you pleasure, but they also may claim reduced appetite. Yeah. So all these are true in the sense that they are related to the neurotransmitters released by nicotine interaction with the receptor. So we want the students to really understand this. But there are also other effects that are not related to the alpha 4 beta 2 receptors in the brain. For example, there could be interactions between the nicotine and also the receptors on the gastrointestinal tract, the GIT, that would stimulate peristaltic movement that would then help the smoker to have the bowel opening when they go to the restroom or the toilet. So and the students need to anticipate some of the smokers who complain of constipation upon cessation. So some of these effects are related directly to the neurotransmitters, but some are not. So we make sure that the students are aware of this, appreciate, know how to assess severity of withdrawal symptoms or syndrome, given there are various tools out there. So, and also ensure the smokers, when they help the smokers quit, that these withdrawal symptoms, they last probably for about 1 month or so, although weight gain and appetite increase may be longer, but something that they need to reassure the smoker or their patients about, that these withdrawal symptoms that they experience are not lifelong per se, but they can be diminishing over a few days of stopping to few weeks and then maybe few months. Also, this relates to why we then provide the behavior and also the pharmacological interventions. So when we impart the knowledge and have a discussion with the students, we immediately apply it, because the nicotine replacement therapy, for example, the medication, the pharmacological management for smoking cessation are basically given to reduce the urge to smoke and also the withdrawal symptoms. So how do they apply this? It can be mostly under assist. Yeah. So the asking and the advising, we discuss with the students what kind of advice would they use to motivate or to push their patients to quit. So it can be health related and it can be not health related. So we discuss with the students, for example, the using economy, the cost saving of quitting, or maybe cost burden, the cost related to smoking and treatment of the diseases. Or it can be environmental, it can be social, it can be anything. So we try to open the students' horizon, that advice can be beyond health related. Yeah. And assessment, we talked about just now in the pre-quiz, also pre-program quiz, that they probably assess nicotine dependence using Fagerstrom test, particularly for smokers, but they have to use modified tools for e-cigarettes. Okay, and assist is where the bulk of the work goes, because this is where both behavioral and pharmacological interventions would be delivered. Okay, and of course, last but not least, they arrange for follow-up. There are specific dates that we would like to suggest based on the clinical practice guidelines, so that the students are also up to date on this. Okay. Of course, when we talk about nicotine dependence, there's also assessment on tobacco use disorder. We use the Diagnostic and Statistical Manual, the 5th edition, and how to score them. Yeah, as I mentioned just now, this is for the nicotine dependence and scoring. You will see how all these are being put into PBL and also actual patient intervention. So I don't think I should go in depth with the specific contents on both behavior and pharmacological, because that would be maybe too specific for the audience. But if you are interested, sure, you can read through or you can email me if the slides are not available to you, or if you want more information on how we conduct certified smoking cessation service provider program here in Malaysia. Okay, so we go over the types. We ask them, are you going to do individual counseling? Are you going to do group counseling? Or are you going to combine and include other modalities, including phone counseling as well? For the behavior part, we use various strategies. We expose them or discuss with them because we don't know to what extent they have been exposed to this, for example, strategy on motivational interviewing and the details of it, or any other models, yeah, for cognitive and behavioral strategies to support smoking cessation. We talk about that strategy, delay, escape, avoid, and distract a lot. Okay, a lot on that also. And also something cultural and maybe related to not just Malaysians and population, but also maybe other community in the US as well, where they do meditation and also prayers. So this actually took up a lot of time, because we discussed various medications, and there were obviously more medications available in the US than in Malaysia, but at least there were some common medications, and we talk about those. Despite having common medication, there are differences in the dosage formulations as well. So we still need to discuss the differences so that it would benefit both sides when we talk about pharmacological treatment. So we use guidelines, and they have their guidelines, and we then discuss what are the differences and how we iron out these differences. And when we write our treatment plan, it would be the most evidence-based, and then tweak or then tailored to the patient's needs at follow-up. We also talk about tools to assess motivation or readiness to quit tobacco use. And some people are very well versed for the students, including Stages of Change by Prochaska Di Clemente. Some use Y-test motivation rulers to see the readiness. But when we encounter someone who's not ready, we say, okay, let's use the 5 R's rather than the 5 A's. And these are the components that the students were equipped with in terms of knowledge, so that they can motivate the person who was unwilling, if any, unwilling to quit, to make an attempt. Okay. We also included discussion on tools, how to perform or how to use, and where they are applied. For example, carbon monoxide, knowing that it's a product of incomplete combustion of organic materials. Yes, you can measure carbon monoxide in recent uses of cigarettes and other combustible tobacco products, but you may not be able to detect carbon monoxide significantly in e-cigarette users because there's no burning. It's just heated liquids that aerosolize the nicotine. So there's less carbon monoxide. So therefore, you need to be alert of other types of tools. For example, the detection of nicotine level in bodily fluids. And of course, given the time of COVID, we were very concerned about using the saliva, much more other bodily fluids. So we said, okay, we have to use self-reporting, of course, but later when we can safely use saliva, for example, then we can use the saliva test to detect level of nicotine or the metabolite rather, which is cotinine. Okay, so now you're seeing snapshots, screenshots of the actual students. Yeah, the lower part is definitely not student. That's me. And the one in the middle of the screen is Dr. Soraya Ismail from the Faculty of Medicine at IIUM. Then you have RT, Nauka, and Roshni. Roshni couldn't switch on her camera at the time. She was in, I think she traveled back to India at the time, but she joined in. So that's when we had a discussion. We talked about the logistics, of course, and the scheduling and whatnot. And then we pass it to Dr. Soraya, who developed the problem-based learning for smoking cessation, specific for the students, so that it would cover the learning outcomes as well. So she conducted the problem-based learning session with the students. I just joined in and then chipped in when it's needed, but otherwise I was more of an observer. Okay, so as you know, problem-based learning have triggers. So she had, I think, 3 triggers. Trigger 2 was emphasizing on motivational interviewing, on the technique. We want to see how the students then perform the counseling or the intervention using motivational interviewing approaches. And then trigger 3 then is the application of the 5 A's when it also involves the use of the medications. Okay. Of course, I mentioned we talked about e-cigarettes to a certain extent. We talked about the dangers of delivering rapid amount and rapid and high amount of nicotine to the brain from the electronic cigarettes because they can deliver higher amount of nicotine than conventional cigarettes. So we talk about the pros, if any, but mostly about the cons, the arguments against e-cigarettes. In tandem with the WHO stand regarding e-cigarettes, so we have a discussion on this as well, as opposed to maybe some countries that advocate the use of e-cigarettes. We constantly get feedback from the students. We have a WhatsApp group that we created earlier on. Actually, I think we also have another person who helped us. He's my master students. His name is Azahari. So he also provided some inputs, as well as another faculty member here, Dr. Shahri. So he helped with the IT related component, like the online quizzes and the analysis of data and whatnot. Okay, so you can see here some of the feedback when the students need a given information, for example. Then they ask questions, so we sometimes just provided the answer through the WhatsApp, and if they need more clarification, then we put that in the time slot that we have for the program. So they were all praises at the end, and what I like is that they closely monitor the patient. If you can see here, they followed up their patient even after they have finished supposedly their rotation with their attachment with us. Yeah, even that was, I think, maybe close to month of May. They finished in April. So some of the dates were changed a bit or move forward, but that really showed to us here that as preceptors, they were really applying, and they were actually helping actual patients. Yeah. So with the consent of the patient, of course, I mentioned earlier, they managed to get the consultation session, among the three of them, the students here, with the actual patient. So I cover her face for maybe anonymity. But anyway, we then observed and then provided feedbacks on the good points that they actually were able to apply, and maybe certain things that they can look into to further improve their interventions. So then they wrote and sent us the report. As you can see, this is the way that they are accustomed to writing a report: from the chief complaint, history of presenting illness, past medical history, past medication, social history. So they were very thorough. We talk about not only the number of cigarettes, duration of smoking, and so on and so forth. Why medication is important? Because there are medication and smoking interactions. And also we also need to know about their attempts and the social history. We talk about caffeine just now, alcohol use as well, and medications and other important or relevant information, and their assessment. Okay, and how they get this information from the patient, the quit date that has been set, and what they plan to do or what they have given, and what they plan to do next at the follow-up. So all this were discussed and commented upon. And last but not least, remember I said they did the pre-attachment assessment. So you can see here, they all showed improvement in their knowledge for pre versus post attachment assessment. Okay. And there was a cultural immersion virtually done, because towards the end of the month, or maybe I think maybe towards the end of the month, or the whole month perhaps, we were having fasting month in Malaysia. All Muslims all around the world were having their fasting. So my postgraduate students then shared videos, live streaming videos or recorded videos with the students from University of Pittsburgh, how Muslims actually observe Ramadan, from the breaking of fast to the prayers and activities during the night and whatnot. So I'm not going to show you the videos, but it's okay. It's just short ones, but I think time is short. So I'll just summarize by saying that, yes, it's doable, it's feasible to have an extensive, we can have the virtual training program. We develop, you need to have a proper and extensive development of online platform training that will connect the world over, not only Malaysia and US, where students virtual attachment and mobility programs conducted at very minimal cost, okay, if any. A suitable module where we embedded problem-based learning was also successfully designed and conducted to also suit the online platform and the intended students. So like to acknowledge all those involved from both universities, and also like to thank the organizer of this summit for allowing me to share my experience for the virtual training platform program. Thank you so much.
Thank you so much, Professor Haniki. So thank you so much for the inspiring sharing. So now we will open the floor for questions. So please feel free to propose your questions. If you wish to propose your questions, please key in your questions in the chat. Then we will invite our keynote speaker to respond to you shortly. So maybe I ask the first question. So because we usually when we talk about virtual exchange, we're talking about maybe we ask the students to collaborate on certain projects, maybe they interview one another to, have some firsthand data that then help them with the assignment. But this time, because this is about something on clinical, so you have bring up something very new to us. It's like talking about the virtual attachment. So it's actually something that we feel like it's very interesting. So may I ask, while we talk about virtual attachment, it's not talking about the asking the students really like sitting together and then to discuss something. Maybe there will be some certain components like that, but it also would be asking the students to, looks like they were, presence on the clinics. So is there any difficulties, anything that in the arrangement that need to be, carefully pre-planned before bringing it out into reality? So could you share your experience with
Yes,
us?
wonderful question. As mentioned just now, we deliberated on how we're going to have the students apply their knowledge and skills gained through the training. But we were blessed when we discussed earlier on. We were told that they could get patients from their facility. So that was a life-saving moment. If not, they have to then intervene using our patients. And we identified maybe there were going to be issues like language barriers, time issues, and whatnot. And whether any of our patients are willing to be sort of interviewed or intervened by the students. But we said we'll try. If they couldn't get any actual patient from their side. But luckily enough, from the very beginning, we were told that they have this clinic where the faculty members actually serve to the community. And they know that they have smokers that they can actually use and invite the patient for teaching and learning purposes. And yeah, we were lucky that we have. So in reality, if we talk about the broader perspective of clinical attachment, yes, depending on the type of clinical attachment, you have different services and specialties. So there would be opportunities for interprofessional learning, whereby you may also have students from medicine or nursing clerking the same patient. For physical, yes, we have done that. We have done actually interprofessional learning on smoking cessation virtually, also during COVID, whereby we invited students and faculty members from Faculty of Medicine, Nursing, Allied Health, Dentistry to join in. So they submitted the names of the students who can participate. So we send them the triggers, and then we break them into groups and ask them to reconvene, provided the guidelines, the instructions, so that for each group, they would have at least one representative from the different faculties. So we give them a case of a smoker, and we see how they were able to provide the counseling. And they submitted excellent videos of mock session because they were doing it because they couldn't go to the hospital. So they appointed someone as a smoker, someone role play as a provider or the person providing the intervention. And they then they took different roles for different case. So yes, we have done even virtual IPL, and but this was not a request or a need, because remember, from the EDI model, we have to analyze first. So what do the students need as well as the faculty need? So they needed a very specific focus attachment on smoking cessation. There was no request on interprofessional learning or even other types of learning for this program. But in the future, yes, we can have more.
Yeah, thank you so much. It also I would like to have follow-up questions. So how about the students? So this is about the students learning some expertise, somehow more like clinical experience, like virtually, through the virtual attachment. But how about, is there any possibilities for the students like really to interact with their, peers virtually during the practices, so they can have more like more in-depth discussions regarding the virtual attachment, that meaning giving them possibilities to learn with one another. Like one is like there's something that maybe because they're not on site, so they really could be tell by, if you go into the patient, you're not directly just like asking. It's also about the nonverbal, cues that being given, the how well they are, how they want to be, really stay firm about want to get rid of the smoking or something like that. So it's somehow that it also what, how do we supplement those nonverbal, you know, because of we cannot be on the site. So how can we supplement those like nonverbal cues be revived in the virtual platform? So is there any discussions between the students on site and also those on the virtual attachment then?
Yes. Another excellent question. We mostly focused on the knowledge and skills. And of course, we talk about effective communication. And we do not know what or how they perform at the actual site when they practice. But we were lucky enough, they had a live session with the patient when they allow us to join. So yes, all those points that you mentioned, we were able to comment upon. For example, because usually is many patients can be in a group session and one person will be running. This one is a flip. You have three people providing the intervention, and you have one patient. So I also actually with also Dr. Soraya, we looked at soft skills or lifelong skills, living skills, like teamwork, how they respect each other, how they were able to give another person opportunity to ask questions to the patient respectfully, and how they interact with one another apart from their interaction with the patient. The one thing that I missed though, I think, was that we were not able to um, assess the patient. We want to ask the patient to provide us feedback regarding the session, but we have to respect the patient's wish that she only allows the students to talk to her. So during the session, we were not commenting on anything, but we will focus on how the students interacted with the patient and also among each other. So that we wanted them to not only improve on their knowledge and skill, but also their teamwork, leadership skills as well.
Okay, so thank you so much, Professor Haniki. So it's great to know, and I think it also has opened up something that really let us know that virtual exchange is not just more than the usual practices that we're having. It could be something that very practical, way of doing, especially when we talk about something on the medical purposes. So thank you so much.
My
So
pleasure.
yeah, thank you. So actually, I think because we are having the panel sessions actually has already kicked off. So and sorry for the technical problems at the beginning that we have postponed a little bit at the beginning. So I have sent up the feedback form here. So it would be appreciated if you any our audience will be giving us feedback so we can be better next time. So I also would like to seize the chance to share you the QR code here. So you can simply scan the QR code, then you also can give us feedback directly through here. And please also help me to have the great applauses to somehow we would like to thank you for Professor Haniki to deliver us this inspiring talk. And I do see that Professor Haniki also shared his email. So if you want to know more about his research and want to know more about the experiences that he has shared, so please feel free to reach him. So thank you so much. And please let me to share you also like we want to thank Professor Haniki once again for his enlightening presentation. So we hope that we can have more collaborations with IIUM and with us and also with our partners around. So I want to also seize the chance to share that we're ongoing now with other panel sections. So if you are interested, you're welcome to join. I'm going to show you about the panel sections actually ongoing at this moment.
Okay, I can join.
Yeah. So, and also to our audience then. So actually we have two ongoing panel sections after Professor Haniki's talk. So we have one is about health and well-being across the globe, which is now on currently having, the section. And the other one is about virtual exchange and global citizenship. So if any of the audience interested, welcome to join through the Event X platform. Then we also have our last keynote later today in Hong Kong time, 5 p.m. So we have another scholar from Spain sharing us some, his coordination experiences in Europe. So we also have the last two panels today, and also the last two panels is at the summit later today, starting quite late. It's 6 p.m. in Hong Kong. So thank you so much for joining us today, and thank you so much for joining this keynote section. So we hope to see you in the later sections. Thank you, Professor Hamniki. So have
Thank
a
you.
great day.
Bye-bye. Have a great
Thank
day, everyone.
you. Bye bye.
So I leave this one and then join the
Yeah.
other link.
Yeah, welcome. So
Thank
you
you.
can click on the event X, you have your own link. Have you got your own link? Yeah, just like clicking on that, then you can join other sections.
Thank
Let
you
me
so
know if you
much.
cannot. Thank you.
Bye.